everyone. In this keynote lecture, we'll be discussing the utility and application of minimally invasive surgical staging in the management of esophageal cancer. First, let's start with some background about the disease. Esophageal cancer is currently the sixth leading cause of cancer-related mortality and eighth most common cancer worldwide. It's estimated that in 2015, the United States will see nearly 17,000 new cases of esophageal cancer and experience about 16,000 deaths. Despite our best efforts at treatment, 5-year survival for this disease remains poor at 15 to 25%. These poor outcomes are largely due in part to the typical presentation of the disease, with diagnosis occurring at late metastatic stages and the propensity for even superficial tumors to metastasize. Survival is improved when esophageal cancer is detected at an earlier stage. Once the diagnosis of esophageal cancer is made, accurate staging is essential to ensure that correct treatment protocols are applied. Tumor stage, estimated prognosis, and the patient's physiological status are assessed together to develop the proper treatment plan for each individual. Esophageal cancer is staged according to the tumor node metastasis staging system. The TNM system was first introduced by the International Union Against Cancer in 1968 and has undergone multiple revisions since that time. The T stage represents depth of tumor invasion, N stage represents regional lymph node status, and M stage represents distant organ metastasis. In 2010, the American Joint Committee on Cancer released the 7th edition staging system for esophageal cancer. Notable modifications made in this edition include the classification of T4 lesions as either resectable, T4A, or unresectable, T4B, the stratification of end stage by the number of lymph nodes involved, and the stratification of overall stage according to tumor histology, grade, and location. This figure depicts the TNM staging system applied to esophageal cancer. T stage is based upon invasion through the esophageal wall layers. T1 lesions, which involve the mucosa or submucosa, T2 lesions involving the muscularis propria, T3 lesions invading into the adventitia, or T4 lesions, which involve adjacent structures like the aorta or pericardium. The end stage is stratified based upon the number of lymph nodes that are affected by neoplastic cells, and the M stage is based upon the presence of metastasis to distant organs such as the liver or lung. This is a table of the Ajcc 7th edition overall staging criteria for adenocarcinomas of the esophagus. As you can see, the TNM criteria, which we reviewed on the previous slide, is combined with tumor grade in order to determine overall stage for a particular patient. Squamous cell carcinomas of the esophagus also incorporate tumor location into the system to determine overall stage. A higher stage will typically portend worse prognosis for a patient and usually requires a more aggressive therapy. A multimodality approach is necessary to determine the stage of an esophageal tumor. Patients with esophageal cancer typically present with clinical symptoms like dysphagia and weight loss. Evaluation of these patients will begin with a full history and physical exam, along with a barium swallow. Endoscopy is useful for visualization of the lesion within the esophagus. Non-invasive imaging techniques like PET and CT are also helpful to assess the local spread of disease as well as distant metastases. Additional endoscopic methods, such as EUS, are used to assess the T stage, giving detailed info about the esophageal wall as well as nodal status. Finally, at some institutions, minimally invasive staging with laparoscopy and/or thoracoscopy are performed in select patients. We'll now delve a little deeper into each of these modalities. An esophagram, or barium swallow, is often the initial test in patients with a history or clinical features of esophageal stenosis. A barium swallow will typically reveal a stricture in the esophagus where the lesion is present. An esophageal gastroduodenoscopy, or EGD, is another helpful procedure that permits a visualization of the lesion within the esophagus. EGD can be used to biopsy the lesion and obtain a formal tissue diagnosis. It also helps determine the proximal and distal extent of the disease, as well as assess possible involvement of the stomach. Due to low cost and widespread availability, CT imaging of the chest and abdomen is frequently obtained in esophageal cancer patients. CT imaging is helpful in depicting tumor growth and the loss of fat planes between the esophagus and surrounding tissues, which is suggestive of local disease and inflammation. CT imaging has limited utility in the assessment of the depth of tumor invasion through the esophageal wall due to its limited resolution. However, it is able to increase the accuracy of evaluation of the primary tumor as well as adjacent organ involvement such as the aorta. However, the highest utility for CT imaging is in the identification of distant metastases to organs such as the lung or liver. CT imaging is also used to identify enlarged lymph nodes that are a suspicion of tumor involvement. However, the results of several studies have raised concerns over the accuracy of CT for identifying small lymph node metastases. In 2000, Lukatich and colleagues studied 53 patients with potentially resectable esophageal cancer who were staged by both conventional imaging as well as minimally invasive staging. They noted that the sensitivity of CT for identifying lymph node metastases was only 33%, and moreover, CT proved inaccurate in over 40% of patients as compared with minimally invasive surgical staging. PET imaging is increasingly being applied in the staging of esophageal cancer. PET, like CT, is limited in the assessment of T-stage, and its primary benefit is in the detection of distant metastatic disease. In fact, studies have shown that PET imaging can identify distant metastases in patients who have negative CT scans in 10 to 20% of cases. The reported accuracy of PET in the detection of nodal metastases varied, with reported accuracies ranging from 27 to 90%. The combination of PET and CT is superior to PET alone in the assessment of nodal staging. However, its reliability for assessing local regional lymph nodes is questioned, particularly when the node is in close proximity to the primary tumor. Since its introduction to clinical practice in the 1980s, endoscopic ultrasound has rapidly grown into a reliable technique for assessing lesions of the GI tract. EUS visualization can display 5 distinct layers of the esophageal wall: the echo-superficial mucosa boundary, the mucosa, the submucosa, the muscularis propria, and the adventitia, and has represented an important advance in esophageal cancer staging. In the assessment of T-stage, EUS has reported sensitivities of 85 to 90% and accuracies of 70 to 80%. Moreover, the addition of fine needle aspiration has proved useful in the detection of regional lymphadenopathy. However, EUS has important limitations affecting clinical staging. With the recent surge in endoluminal therapies like radiofrequency ablation, endoscopic mucosal resection, and photodynamic therapy for lesions limited to the muscularis mucosa, it's become particularly important to accurately stage these early-stage lesions. A study by Bianco and colleagues from the University of Pittsburgh demonstrated that EUS accurately staged just 39% of T1A lesions and 70% of T1B lesions. Similarly, Bergeron and colleagues at the University of Michigan found that only 39% of T1A lesions and 51% of T1B lesions were correctly staged using EUS. Moreover, in Bergeron's study, lesions thought to be node negative turned out to be node positive in over 15% of cases. Endoluminal therapy would undertreat these patients. No imaging technique, including EUS, is accurate in distinguishing mucosal lesions from submucosal lesions. EMR may be useful in staging superficial esophageal lesions. EMR excises a disc of tissue from the esophageal wall with a resection plane at the interface of the submucosa and muscularis propria. Histopathological assessment of these specimens allows for the accurate identification of submucosal invasion, which is associated with high rates of lymph node involvement and warrants esophagectomy. A small study by Maish and Demeester stated that EMR was accurate in determining the depth of tumor invasion in 100% of patients with at most T1 disease. Moreover, EMR completely excised the tumor in 86% of these cases. They recommend EMR as an adjunct to EUS for the staging of early-stage lesions. This brings us to minimally invasive surgical staging, which includes the techniques of laparoscopy and thoracoscopy for the evaluation of esophageal tumors. While not widely practiced, minimally invasive surgical staging can have clear benefits for select individuals. In terms of current clinical recommendations, the Society of Thoracic Surgeons recommends MIS staging for locally advanced adenocarcinomas of the gastroesophageal junction that infiltrate onto the gastric cardia. The National Comprehensive Cancer Network considers MIS an optional part of the staging process in patients with lesions of the gastroesophageal junction without evidence of metastatic disease. Two major advantages of minimally invasive staging are the identification of patients who might benefit from neoadjuvant therapy due to the improved detection of locally advanced disease, as well as the potential avoidance of non-therapeutic laparotomy due to the enhanced detection of distant metastases. We'll now discuss these advantages in further detail. To date, there's been one prospective trial investigating the feasibility of minimally invasive staging in esophageal cancer. Calgb 9380 was a multi-institutional National Cancer Institute funded Phase 2 trial that included 134 patients. The primary objective of the study was to evaluate the feasibility of minimally invasive staging as a staging modality, with secondary goals to assess MIS accuracy and clinical benefit. Minimally invasive staging proved technically feasible in 73% of patients, with no mortality or major complications. Additionally, positive nodal disease was found in 56% of patients, and MIS doubled the number of positive lymph nodes identified by conventional imaging. In 1997, Lukatich and colleagues carried out a study to compare endoscopic ultrasound with laparoscopic and thoracoscopic staging for evaluating lymph node metastases. This was a prospective study of 26 patients who underwent both conventional and MIS staging. The sensitivity and specificity of endoscopic ultrasound for identifying nodal disease was 65 and 66% respectively. However, the sensitivity decreased to 44% for nodal metastases that were smaller than 1 centimeter in diameter. Minimally invasive staging revealed positive nodal disease in 6 of 8 patients thought to have node-negative disease by conventional imaging. Moreover, while endoscopic ultrasound was unable to detect distant metastases in any patients, minimally invasive staging detected liver metastases in 4 of them. Therefore, we're seeing that the addition of MIS served to increase the accuracy for staging regional lymph nodes, with the added advantage of detection of occult metastases. Calgb and colleagues carried out a similar study comparing EUS and laparoscopic staging for the evaluation of lymph nodes. This was a retrospective review of 47 patients who underwent both EUS as well as laparoscopic staging. Calgb reports that with the addition of fine needle aspiration, EUS FNA had a 90% accuracy for nodal diagnosis as compared with minimally invasive staging. However, when you consider EUS for overall staging, its accuracy dropped to 72% as compared with minimally invasive staging. Additionally, minimally invasive staging was able to identify distant metastatic disease in 17% of patients, which provides a rationale for the inclusion of MIS in staging algorithms for esophageal cancer. This table summarizes the studies comparing the utility of endoscopic ultrasound and minimally invasive staging for the determination of nodal stage. The accuracy of EUS for nodal status is in the 60 to 70% range, but can jump up to 90% with the addition of fine needle aspiration. The sensitivity of endoscopic ultrasound is around 60 to 65%, meaning that this test detects nodal disease in about 2/3 of cases when present. There's also data supporting the improved efficacy of minimally invasive staging in detecting distant metastases as compared with conventional imaging. Minimally invasive staging has a role in patients with potentially resectable esophageal cancer without distant metastases detected by conventional imaging. For these patients, laparoscopy can be used to identify small liver surface and peritoneal metastases, while thoracoscopy can assess invasion of local structures like the aorta or pleura. In one interesting study, Lukatic and colleagues prospectively studied the staging accuracy of PET and MIS staging in patients with potentially resectable esophageal cancer. They evaluated 100 consecutive PET scans in 91 patients with potentially resectable carcinoma of the esophagus to compare the staging accuracy with conventional imaging methods. They found that PET imaging was significantly more accurate than CT in the identification of distant metastases, with an accuracy of 84% compared to just 63% for CT. Nonetheless, PET was still only 69% sensitive in the identification of distant metastases as compared with minimally invasive staging. There were 18 small metastatic lesions that were missed by PET scan but detected by MIS staging. All of these lesions were less than 1 centimeter in diameter and predominantly included the liver, pleura, and lung. These findings suggest that minimally invasive staging may be useful for the detection of unsuspected distant metastases after PET scanning. Here are some figures from the study. On the left, we're seeing a false negative PET scan that demonstrates increased focal tracer uptake only at the site of the lesion near the gastroesophageal junction. This gives off the impression that the patient does not have distant metastatic disease. However, on the right, in the same patient, we can appreciate a 6 millimeter liver metastatic lesion that was identified by laparoscopic staging but missed by both PET and CT imaging. Similarly, Dr. Wynn and colleagues prospectively evaluated the efficacy of minimally invasive staging in a series of 33 patients with potentially resectable esophageal cancer who underwent both conventional imaging and MIS. They found that minimally invasive surgical staging accurately determined resectability in 97% of patients compared to just 61% for conventional imaging. The use of minimally invasive staging was able to avoid an unnecessary laparotomy in 10 of their 33 patients in this series. The largest investigation in this area occurred in 2007 when DeGraff and colleagues retrospectively reviewed the records of 416 patients with esophageal cancer referred to their center over a 7-year period. They found that minimally invasive surgical staging had a sensitivity of 88% and specificity of 100% in the identification of operable disease. Moreover, the addition of MIS was able to avoid non-therapeutic laparotomy in 63 patients who actually had peritoneal or liver metastases. This is a compilation of studies that have compared minimally invasive staging and conventional imaging in terms of their ability to determine resectable disease. In this context, unresectable disease would be due to the presence of distant metastases, locally advanced disease, or extensive lymph node involvement. Minimally invasive staging has increased accuracy in making the determination of resectable disease. Most importantly, its specificity is 100%, suggesting that patients without operable resectable disease will avoid a non-therapeutic surgical procedure. On the other hand, conventional imaging has a considerably lower accuracy for determining resectable disease. Its specificity of around 91% is still high. However, this suggests that some patients without resectable disease may undergo a non-therapeutic laparotomy, which carries a mortality and morbidity risk. Despite the apparent benefits, minimally invasive staging is not widely practiced due to some perceived limitations. Multiple reports note that staging laparoscopy has limited utility in tumors of the proximal esophagus. In one study, DeGraff and colleagues noted that none of their patients with lesions affecting the proximal 2/3 of the esophagus experienced a change in management following minimally invasive staging. Additional limitations of staging laparoscopy include the typical risks of intra-abdominal laparoscopy, like bleeding, infection, injury to the esophagus or nearby structures, the cost of the procedure, and the risks posed by general anesthesia. The use of routine thoracoscopic staging in esophageal cancer also remains controversial. The detection of metastases to the pleura or lung, or local into unresectable structures, has led some to advocate for VATS staging as a tool to avoid an unnecessary thoracotomy in patients with unsuspected intrathoracic disease. However, in some studies, no unresectable disease was identified in patients who underwent VATS staging. These patients were thus exposed to longer operative times, and some required hospitalization. Accurate preoperative staging of esophageal cancer is imperative to select appropriate treatments for patients. Minimally invasive staging techniques, such as laparoscopy and thoracoscopy, may provide a more accurate assessment of advanced local regional disease and distant metastases as compared with conventional imaging techniques like CT, PET, or EUS. Minimally invasive staging can be considered for patients deemed to have resectable cancers by conventional preoperative imaging to identify those who may have unidentified distant metastases, thus avoiding a non-therapeutic laparotomy, and identify unsuspected locally advanced tumors where a multimodality strategy should be utilized. Our primary approach to esophageal resection is with a minimally invasive approach. With the shift in epidemiology and increasing incidence of adenocarcinomas, primarily located in the distal esophagus and gastroesophageal junction, we routinely proceed with laparoscopy prior to definitive resection due to its enhanced ability to detect small foci of metastatic disease. We have found that laparoscopy is particularly valuable in the detection of occult distant metastases and exclusion of patients from definitive resection. The definitive resection can be accomplished with either a minimally invasive or open approach. We perform staging thoracoscopy infrequently and more selectively. Further studies are required to more clearly define the role of minimally invasive staging in esophageal cancer. Thank you for the opportunity to present this talk on minimally invasive surgical staging for esophageal cancer.